Okay, it is 12:01, so we'll go ahead and get started. I want to welcome everybody to Medical Grand Rounds here at the University of Colorado. I have just a couple of announcements today before I introduce our speaker, Dr. Rana Awdish. The first announcement is COVID is here, as you are all aware. Numbers continue to remain high at all sites. I would say we are in this plateau and it continues. I want to remind everybody, if you need support for yourself, support for others, please don't forget to use the Department of Medicine webpage. Go under Faculty and Staff Affairs. There you'll take you to the COVID page, and there is where we have COVID resources, practical ones for clinical care, and also ones for your own well-being, and just reminding everyone to take advantage of that. On the good news, we are not entering an ACGME emergency this week. I know that's been on a lot of people's radars. Numbers are bad, but our trainees continue to be productive. And so that will be held off and likely made on a weekly basis every Monday. So I will keep people posted whether that's going to happen, but no ACG emergency for right now. And good news, we got our fellowship match today. I just want to offer congratulations to all the fellowship programs who had excellent matches, and to our residents who I got to see where they got into their fellowships. We'll be sending that out to the faculty later today. But suffice to say, it was a truly excellent match. Now on to Medical Grand Rounds. I want to remind you to please use the Q&A feature to send your questions in for Dr. Awdish. The chiefs and myself will gather those for a conversation at the end of the talk. And I want to also remind everybody that all of our Medical Grand Rounds this year are open for CME and mock credit. So please use the link that Kelly will put in the chat feature to go ahead and get your credit. And now on to introducing Dr. Awdish. So Dr. Rana Awdish is a pulmonary and critical care physician in Detroit, Michigan. She got her undergraduate degree from the University of Michigan, go blue. She then went on to receive a master's in medical science, as well as her doctorate from Wayne State University School of Medicine. She did her internal medicine residency training at Albert Einstein in New York, and was a pulmonary and critical care fellow at Henry Ford Hospital, where she works today. She's currently an associate professor and a clinician educator at within the Department of Medicine at Wayne State University. She holds many leadership roles within her hospital and also within our many professional societies. She is the medical director for the care experience at Henry Ford Health System. She's also the director of the pulmonary hypertension program, where she does a lot of her clinical work. She is faculty in the WHEEL program, which is Warriors Engaging in Empathy Through Literature, which is a curriculum based on the book we'll speak about a little bit later. She's also a faculty advisor to the Narrative Medicine, the Humanities Interest Group at Wayne State, and a faculty advisor to the Humanism and Medicine Seminar, which is the student chapter of the AMA. Much of her clinical work and published work focuses on pulmonary hypertension on the one hand, and on patient safety and the patient experience on the other. She's been the recipient of too many awards. It would take all of her time if I read them all. But suffice to say that she's been the Critical Care Physician of the Year. She has been named the National Compassionate Caregiver of the Year by the Schwartz Center back in 2017. Press Ganey named her 2017 Physician of the Year. She was named a hospital hero during the COVID crisis and honored by David Brooks in the New York Times with a Sidney Award most recently for her piece, The Shape of the Shore, which many of you have read. She's very well known, not only within medical circles, but also outside of medical circles. Her book, In Shock, How Nearly Dying Made Me a Better Doctor, transformed how many of us think about the patient care experience, certainly in critical care. You may have seen her on NPR, in the New York Times, other papers of record. And so it really is my honor today to welcome Dr. Rana Awdish to our Medical Grand Rounds. And we're just so excited to hear you speak. Thank you for coming today.
Thank you so much, Dr. Connors, for that very generous introduction. Whenever I hear things that I've accomplished, I also feel compelled to let people know that in undergrad at University of Michigan, I accidentally electrocuted my physics lab partner, and he was sent to the infirmary, badly singed, and I failed the lab and thought I would never get into medical school. So a failure story to start and round off that CV. I've titled my talk today, Healing with Intention, out of a real awareness that we are in an intermediate space right now. And there is much that we are working through in real time. Many of you have probably come directly from caring for COVID patients. And so I offer this talk by way of respite, a hope that it will be generative and an open space for discussion. No matter what, one thing we have in common these days is we're all living a life that looks at least a little bit different than what we expected on New Year's Eve of 2020. The pandemic and the twists and turns of it have just been unexpected and unplanned. And I think, honestly, if we could have known then what it would look like and for how long, we wouldn't have been better off. For some of us, charting a path that's been disrupted is not necessarily new. For example, though I planned on becoming a critical care physician and that worked out, I couldn't have anticipated becoming suddenly critically ill at the end of my training or spending years seeing all of medicine from a vantage point of a critically ill patient. That was a twist. And what that unexpected detour provided me with, and what I think this time potentially provides us with, is an increased ability to discern beauty and love, even amid tragedy, and ability to hold the good with the bad. I certainly needed that skill desperately back then when I was so critically ill and things often seem hopeless. But honestly, I think I've needed it even more in the past 2 years. As a critical care physician at Henry Ford Hospital in Detroit, we've been hit incredibly hard by the pandemic, and there has been tremendous suffering. And I in no way want to fetishize the pandemic, but there also have been real moments of healing and beauty. When I look back at pictures of us from the first wave, honestly, what you see is incredible. This is a picture of our Pod 4 medical ICU nurses. And Detroit Henry Ford Hospital is old. It's 100 years old. So there's actually only one medical ICU that has doors. The rest are curtained bays. And so this area was the first to turn into a COVID unit and has remained a COVID unit really throughout the last 2 years with very little in the way of a lull. And yet, when you look at these nurses, what you see is dedication and purpose and even a sense of joy. In that first wave, we were so united in a singular goal, the shared purpose of attending to the sick in our community. And at that time, really felt like we had the support of our community by staying in, really sheltering in place so that we could potentially not be flattened by that first wave. I learned so much about us during that time. I started doing a sort of wellness rounds on the teams that were taking care of COVIDs after my clinical rounds. And I made it a practice of going to each unit and just asking whoever wasn't terribly busy what the hardest part was for them that day. It was all changing so rapidly then. And my friend in the back there who's waving, I was particularly worried about her because I knew she had just undergone a fairly aggressive therapy for cancer. I was worried she was immunocompromised. We didn't know much. We had no vaccines then. And so when I saw her, I said, how are you handling all of this? It must be so terribly hard. And she said, this is the easiest part of my day. And that surprised me. It turns out that her sister was actually dying in a hospice in the area. And because Tracy, the nurse, was an ICU nurse caring for COVID patients, she wasn't allowed to visit her sister. And she told me that just being in the ICU and being able to touch and care for her patients physically, to be present for them, was so meaningful because she knew her sister was without that. And at the end of her shift, she would go to her sister's nursing home and she would literally put her hands against the glass of her sister's window from the outside, just hoping that her sister would sense her presence and would know that she was there. On the day that her sister died, she had clung to the window for 9 hours. And what she did was a beautiful act of love. And it reminded me that we know how to love each other, even when we're constrained by risk. But more importantly, what it reminded me is we rarely know what's difficult for somebody. We often make assumptions about what is hard, but unless we ask, unless we show up with genuine concern and compassion, we may not know. I'm sure most of you have been dealing with COVID directly. Some of you may have also been dealing with parenting during a pandemic and homeschooling. Regardless of what you've dealt with, this time has been intensely challenging. And I've heard people refer to this time as having scarred them. And to be honest, I'd prefer that we think about it as having wounded us instead, because in the time between when the terrible injury happens and when the scar inevitably forms, there's a real possibility for healing. This can be so difficult to remain open and vulnerable when we're taught to just lock all of it in a box and look at it later. Medicine has not always provided us with safe spaces for reflection and disclosure of what's hard. But when we do that, when we partition our experiences, when we ignore our very human suffering, we miss the opportunity that comes from intense hardship. We get all of the hurt and none of the benefit. Our injuries offer us a window, provided we're willing to look. I've spent quite a lot of time thinking about the process of healing, how we heal when we've suffered from an injury that overwhelms us and threatens to obscure our view. The first time I had to figure this out was in 2008, when I had a very catastrophic intra-abdominal hemorrhage that nearly killed me and ended our first pregnancy. It coincidentally happened on the last day of my pulmonary and critical care fellowship training. I thought I knew how to care for my patients. I thought I knew what my patients needed from me, but certainly the universe understands irony, and spending the next several years critically ill myself showed me that there is a whole aspect of healing that medicine can really be blind to. When I got sick, I was very comfortable in my identity as a critical care physician. I was attached to that identity. But as I learned, our identity and our lives as we know them can really dissolve in a moment. And it can be a terribly frightening thing, but it's also an opportunity. I entered the hospital, as I said, as a critical care physician, and I left months later in a wheelchair. I was unable to walk even a few steps unassisted. I had had a stroke from the lack of blood flow to my brain. With the hemorrhagic shock, I'd required 26 units of packed cells, an additional cryo and platelets, an FFP. I'd gone into multi-system organ failure, liver failure, kidney failure. I was inarticulate and very slow. I was what we used to call a respiratory cripple. I was dependent on oxygen. I had a terrible loculated pleural effusion and trapped lung, which was unable to be decorticated. I couldn't put on my socks unassisted. And to be honest, I no longer resembled myself. I wasn't what anyone would consider a physician. I was no longer an expectant mother. I felt barely recognizable. And it was really from that place that I had to completely reimagine my identity. And I remember encountering this quote: "Healing requires entering with intention that which you have run away from." So, what had I run away from? Or another way of looking at it, what had I run to? My identity as a physician gave me a sense of separateness, of strength, of wisdom, which meant that in some ways I was running away from vulnerability and humility and an awareness that there is no certainty and we don't have all of the answers. As a patient, I was absolutely humbled and vulnerable. And when I think about this time that we're inhabiting and what this time has revealed about us, about medicine and the society that we've structured and who it disadvantages, and the structural inequity that we've built into the system, I think about how healing those things is going to require that we turn towards them and that we truly regard those things that we have run away from. Because all of us, I think, want to be healers. We go into medicine with that idea of what it means to heal. And what my illness taught me was truly that if we are to be healers, we have to attend to the full spectrum of the patient experience. And to do that means discriminating between illness, disease, and sickness. Illness is the health that the person identifies themselves with, their sort of self-reported experience of their symptoms. It may impact their identity. For example, I have, after my 10 abdominal surgeries, recurrent abdominal pain. I can't really tolerate fat in my diet, although I love cheese. I often have to undergo procedures to dilate or stent ducts. I have lots of operations for incarcerated bowel. I'm often unwell. That is my experience. Disease, on the other hand, that's how we identify the conditions in our patients. In some cases, of course, illness doesn't have a known biomedical cause and there may not be known treatment, but in my case, I know I have recurrent biliary strictures that are the caused by a right hepatectomy that I had. I have abdominal adhesions. And then there's sickness. And sickness is different. It's sort of the role that the person takes in their family, in their community, in society, the social implications of illness. So for me, that means I often miss work. I feel that I burden my colleagues by covering me. I may have shame associated with that. I can't always parent the way that I wish to. That is my experience of sickness. And our perspective on how to attend to our patients changes when we think about these different elements. In medicine, we've been trained to look for and attend to disease. And that orientation can mean that we miss the broader notions of sickness and illness. And if we miss them, then we fail to attend to them. So to do that, I think, requires perspective, which is why I'm showing you this picture. And if COVID wasn't real and we were in a room together, I'd ask you to pick out things that you see in this collection. And it really does appear to just be a sort of organized pile of objects. Someone might see the shark that's suspended. Someone might notice the mannequin that's sitting on a Coca-Cola crate, certainly the piano in the front. There's a clock in the back. Our perspective in this moment doesn't reveal more. We only see the objects. But if we were there and we shifted our perspective, you can see that the artist has created this incredible anamorphic structure of Salvador Dali with these found objects. And I show this as a way of experientially knowing that perspective is this wonderful kind of alchemy that we all have the ability to choose. Our reperception of what we're looking at has the power to transform situations, and situations change as they are seen differently, not because we are altering reality itself. We are not that powerful. Where we have power is in how we choose to look and whether we're willing to look longer and differently or shift and allow ourselves to see the full scope of illness, of sickness, even the whole of the patient experience. If you think for a minute about how we might represent fetal loss in a chart, think about the language of disease, a more tangible example of this. We might talk about how many weeks of gestation the fetus was. We may talk about viability of the fetus. We may reference the reason why the pregnancy was lost. This is the language of medicine. Think instead about how a patient may represent this loss. And what I'll show you next is an artistic representation of pregnancy loss. And I do want to provide that as a warning for anyone who might feel that that is sensitive. So this is a painting that was done by Frida Kahlo, who of course is a master of self-representation and probably the most famous Mexican-American artist. It's titled The Lost Desire, but truly the whole internet calls it Henry Ford Hospital, because that's what she's inscribed on the side of her bed. And she painted this in 1932 when she was living in Detroit. Her husband, Diego Rivera, was painting the beautiful socialist murals at the Detroit Institute of Arts. It's called Rivera Court, and if you ever visit, you should see it. It's quite spectacular. She lost a pregnancy in our hospital, and it was a very desired pregnancy. And you can see when you look at this that she's depicted a very desolate landscape, a sort of post-industrial wasteland, very different than how she depicts her colorful Mexican homeland. It appears that she is very small. She is in the center of the field of view. She is isolated. She's alone. She's not buffering her experience for us. It's said that she asked to see the male fetus, and the doctor would not. He didn't feel that she could handle it in a sort of paternalistic way, decided that she wasn't up for that, and so instead showed it to Diego, who made a sketch for her, and it's from that she painted the baby. You can see that there are elements of the familiar. There's pelvic anatomy, there's a wash basin, there's a bony structure, and she's tethered with cords to all of these things. What I didn't understand when I first saw this was the snail and why she had included the snail. And I found an interview that she had given where she described the qualities of her spontaneous abortion as being just like that of a snail, that it was closed, her body, but also open, that it was soft and excruciatingly slow. When you see the loss of a pregnancy depicted in this way, it gives you a different sense of the scope of the patient experience of illness, of sickness, and of how we might attend to it differently. While we're on the topic of suffering, we can consider our own for a moment. This is a difficult time to connect to our compassion. There is a pervasive sense in medicine of demoralization, lack of appreciation, and really an overwhelming sense of the sacrifices we've all made to do this work. Not that long ago, the limited resources were N95s and gowns and hand sanitizer and ventilators. And now what we've lost, what we're missing, is something different. We've lost that sense that we're all in this together, that individual sacrifice is necessary on a path towards communal well-being. These are difficult times. And when I think about difficult times, what is most often true for me is that it's difficult precisely because it puts me right up against the limits of my own capacity, my coping skills. I get to viscerally experience the limits of my compassion, even the limits of my self-compassion. I come into contact with really hard emotions, my own shame for sometimes blaming the patients for their illness, a kind of moral distress about not being able to care for our patients the way that I think that we should. But what I also know, and maybe you do too, is that incredibly bad things are mappable and they are survivable. That we have come out the other side before and we have been changed by it. And there is no doubt that we will do that again. The term compassion fatigue is one of the ones that's circulating, but I think it's important that we distinguish that from its sort of siblings of occupational burnout and moral distress. So we'll talk about occupational burnout first. I don't like saying burnout without occupational before it, because I really do want to draw attention to the fact that it is an occupational injury. And it's characterized by disengagement, emotional exhaustion, and a lack of feeling like anything you do matters. And I would ask that even if this doesn't feel relevant to you in this moment, that you reserve judgment, because it may possibly be very relevant to members of your team. And you may recognize in your students or your trainees aspects of their behavior that fit within these constructs. What occupational burnout sounds like is I just sit in my car in the parking garage in the morning trying to convince myself that I should go in. I just don't know if I have it in me to do one more shift. With this, tasks feel completely overwhelming. The idea of responding to email, doing one more evaluation, doing your required modules about sleep deprivation, all of it seems impossible. There's a sense of detachment, a loss of motivation. This is not an individual issue. This is not a character flaw. This happens as a direct result of our culture. And this brings up an important point, that when we see a colleague or a trainee who's manifesting symptoms of detachment or disinterest, or seeing unmotivated, not getting back to you about that research project, it's important to assume best intent. We can't make the mistake of ascribing value judgments like, well, he's just phoning it in, he's not the doctor he used to be. We have to think about the ways that we can address the systems issues that are making the work untenable. And the fixes for occupational burnout really are system solutions, and they fall into three buckets, so to speak. Decreasing demands. And by that, I don't mean, we only have clinic once a week now. I mean, what is something that if it were fixed would truly make a difference to your well-being? A fixable solution that would impact your day. For me as a pulmonologist, if the PFT lab could run on time, my clinic would be like a million times better. If I had single sign-on for my computer, that would save me so much time. There are institutional fixes that can actually affect change in aggregate any one of those things may not be enough, but when we all think together about what could change, the culture changes. Enhancing control. So where do you wish that you had more agency? And sometimes that means saying no to projects that you feel like you should say yes to, but that would not bring you joy. Choosing to do work that may not be perfectly suited for your CV, but really invigorates you and lights you up. And finding the support that would actually benefit you. Contrast this to moral injury. Moral injury is the terrible feeling of knowing what the right thing is to do, but not having the ability to do it due to system constraints. The way this showed up in my colleagues was I had to decide between two kids, both of whom will die without transplant. They both needed an ECMO bridge. We don't have the resources to save both. I shouldn't be the one making decisions about who gets to live. These are very real feelings, and they show up as guilt and remorse and shame and despair and outrage. It is caused by a misalignment between values and resources, and this really requires processing as well as an alignment of resources and values. And obviously that's difficult. We're all encountering scarce resources at times these days. When I talk about processing, though, that can take many forms. And interestingly, I think there are a lot of parallels in what we do to help our patients cognitively restructure their experiences. The work that we need to do for each other in these moments, promoting psychological adaptation. This is something that we do for our patients all the time. You know, in the ICU, there are times where we have to reframe what's happening against the patient's experience of it and help them not to distort their experience. Our colleagues are doing the same thing right now. They are distorting their experiences through a lens of occupational burnout or moral injury. The way this showed up for us at Henry Ford was that during the very worst times of the first wave, we had peer processing groups. They're ongoing now, but they seemed incredibly vital back then. And we would all share our worst experiences with each other. And in the sharing, you know, I remember one nurse who felt completely devastated that she was alone in a room having to resuscitate a patient with no one there to help. Everyone was outside, very carefully donning their PPE. And it seemed like it took half an hour for them to get to the room. And she didn't know, do I do chest compressions? Do I push epi? Do I disconnect the vent and bag the patient? What will that do? Will it aerosolize the virus? What am I doing to my family, to my kids? He's going to die anyway. Do I just hold his hands? Is humanity more important in this moment than the epi? She felt so unable to do her job that she came to the peer processing group really devastated. And what happened in that space was beautiful. It was all of her colleagues able to reflect back to her the values that she had embodied in that room. You know, we got to say to her, but don't you see that you stayed with your patient? You did what you could for someone in an unimaginable situation. You brought to bear all the best qualities of nursing. You were navigating something impossible. And through that, she was able to shift her perspective and see herself with a more compassionate lens. That kind of work is something that we can do for each other all the time. We can always reflect the values that we see our colleagues embodying in real time back to them and help them to see themselves more clearly. The act of maintaining the identities of both our patients and colleagues are very similar. Knowing who your colleagues are, what is important to them, their families, what they're worried about, honoring those priorities. Those are ways that we hold people in their identity and allow them to feel seen. We really do that through our attunements to each other and understanding that although we're meeting each other at this point in time, that just like our patients have a life before and after and lots of things they're trying to return to, our colleagues are as well. And then the third piece is the compassion fatigue. And this is the place where we really do have to have strong internal coping mechanisms and reinvest in them. So compassion fatigue is characterized by, I probably don't need to tell you, emotional and physical exhaustion, which leads to a diminished ability to empathize or feel compassion for others. It's sometimes referred to as secondary traumatic stress. It can sound like the patients are here because of their own negligence, and now they are imposing upon my team to treat them while exposing me to risk. It can show up as sleep disturbance, loss of morale, loss of hope, real anger towards the causal agents. It's caused by a convergence of ongoing exposure to a stressful situation and just the overwhelming stress of caregiving, which we've all experienced. This is the only one of the three that really does rely on us having individual solutions. So taking time to disconnect, doing that with some intentionality, learning techniques for self-regulation, self-care, in addition to all of the systematic change that we can advocate for. This piece by Matthew Monahan is titled The Alchemy of Pain. And of course, we all bring different awarenesses when we look at a piece of art. When I look at this limbless form on which he's balanced this very precarious sheet of glass, a body that's been separated into three distinct parts and held together with trowels and nails piercing the surface or ornamenting the surface, depending on how you look at it. When I think about this piece, I think about my own experience of bodily trauma and how that trauma changes the shape of us. This piece really makes me acutely aware of all that we have carried on our physical frame, and how when we put ourselves back together again, that we will not likely be in the same shape that we were before. That not only do we have agency in the shape that we take, but we have agency in the shape that those around us take as well. I've written a lot about how I dislike this idea, this Osler idea of equanimity, that sort of clinical detachment that is somehow deemed to be professional. But I'll tell you, I have a very different understanding of equanimity now, and it's not Osler's version. It's not about separation from the suffering of others or maintaining a clinical lens that's unbiased. It's about having capacity, having enough space for all of it, for the good and the bad and the pain and the beauty, having a heart that's big enough to hold all of the experiences. And when I think about the lessons of this time, the lessons of my illness, I think all of that is about moving towards suffering, both my own and that of others, and having a heart, growing a heart that can hold all of it and not need to numb it or escape it or deny it. One last piece of art. This is one of those pieces of modern art that you could walk past that you could, like I did, say, well, I never really understood modern art. It looks like a bunch of metal posts on the floor. But then you hear the story. So this sculpture was created really in memoriam. In 2008, Sichuan province in China had a terrible earthquake. It was devastating. There were 80,000 lives lost, and 5,000 were school children. They were killed in structures that collapsed because they were unsafe. And the artist and his collaborators went to those schools and they collected 90 tons of mangled steel rebar, and they meticulously straightened each bar by hand and then arranged them into the waves of the earthquake. And it's really an indictment of a system that was meant to protect but didn't. And I walked past this, right? I didn't allow myself to see what it was saying. And I wanted to end on this because I really believe we have to stop walking past the things that we don't want to see. We all have clearly been shown in medicine the structures that are unsafe, not only for our patients, but for each other, for our trainees. We have to learn to not only dismantle the structures, but build networks that support and develop and embody the kind of leaders that we want to be, the kind of care that we believe in, our collective vision of who we are and how we can heal. I'll end with a quick personal story. So back when we were able to travel, I went out to the ISHLT meeting. And of course, because it was in San Diego, my husband and young son came. And we stopped to play on the beach. And I got a phone call that was one of those calls that just stops time. My friend and pulmonary and critical care colleague had stopped by the side of the road to help an overturned car on her way to work. There were 6 teenagers inside. And she was struck from behind. And it was immediately clear from that first phone call that she was not going to survive her injuries. And so as I started to make calls to expand the circle of who knew and console those who were closest to her, my son was just playing on the sand in front of me, and he was seemingly oblivious to my sadness. And I got off the phone and saw that he had built something. And I said, "Oh, what did you make?" And he said, "I made you a cemetery. This grave's for your dad, and this one's for my sister who died in your belly, and this one can be for your friend because she's dying too, and mom is sad." And I remember in that moment wishing that he had a reset button, or that I could just get a new one, because there are all these children who are building sandcastles, and my kid has made a cemetery. And I felt like in some ways I had practically curated his loss of innocence, that he only knew sickness and death from my own illness and my work in the hospital. And then I had another surgery, and he came into my room and said, "Mama, is your pain small, like the size of a quarter where they did the incision, or is it so big it takes up the whole room and there's no space for me?" And I remember in that moment thinking he was going to be okay, that he had somehow metabolized everything that he had seen and been through, and had a kind of awareness of empathy that would serve him, and that it was better than our stupid 1 to 10 flat pain scale, that pain really was 3-dimensional. And so that is my hope for all of us. May we metabolize our pain. May we use it to soften our hearts and transform our communities, and truly invest in our vision of what's possible. Thank you.
Dr. Awdish, thank you very much. You not need me to tell you this, but you are an incredible person and an incredible speaker. And it's great to have you here. Thank you so much.
Happy to.
We have a number of questions from our audience. Not surprisingly, we'll try to get through as many as we can. And many of them I think are long because I think people wanted to speak to you and with you. And I'm sorry you couldn't be here today to do this, but the first question says that your story is incredibly moving, and I'm struck by your extreme resilience. I find that many of our providers, from nurses to physicians, are feeling this sense of burnout related to the seamless endless suffering brought on by COVID. How do you tap into your own sense of resilience? And do you have any broader recommendations from a provider standpoint how to do this?
I had to write about this recently. I was asked by Annals to try to address this idea of how the heck do we do this right now? And what I realized I was doing myself was just holding on to sort of this very thin thread of what I believed. And it's very thin at times, and sometimes I drop it, but it truly is that the person in front of me is a human, and I can't possibly know all the experiences that led them to make the choices that they've made that got them in front of me. And they may never have experienced compassion. They may not have the health literacy that I am privileged to have. And that if I can just hold on to my own value of compassion and kindness, that at least on the other side of this, I'll still recognize myself. I think that we can't do it for other people anymore. We've lost that ability. I can't channel that for the person, but I can still channel it for myself because I want to still respect myself on the other side of this.
And if I can just a clarifying question, is that how you define resilience? Because I know that's even a tough word in itself, because it is, I would say, double-edged, the word resilience.
Yeah, it's been a little bit co-opted, right? And so there's this idea that we can be just shored up with these resources so that we can bounce back from hard experiences. And I think my understanding of resilience for myself is a little bit different. It's being able to have that capacity to take whatever comes with a kind of constancy that serves me. And I do all sorts of things to make that possible for myself. I do try to disconnect. I do take breaks from technology. I do enjoy reflective writing and reading, and those things help. But I think without an intention of maintaining our identities through this, none of that really matters.
Thank you. You described poignantly the conflicting emotions that come with dealing with some of our unvaccinated patients, which is a large population of our inpatients right now, and the fact that you can feel anger toward the situation, and then shame at your own anger, and then maybe even anger at shame. And there's obviously a cycle there. How do you quiet that at the end of the day? How do you put that to rest so that you can go home and be with your family, or even just fall asleep?
Yeah. I believe in listening to our emotions, that they have important things to tell us, and that if I am moved to anger, that really means I want things to be different. And we've got so much of that signal right now, it can be difficult to acknowledge it. But every time we realize I'm angry because this person is unvaccinated and they are risking the lives of others, we're also realizing that our public health infrastructure is broken, that our communication strategies are not effective, that we're a little bit removed from our communities. And those realizations are a bridge to change. And so I really welcome the feeling as a kind of trigger to me to what my values are and where I want to work. Because it doesn't have to stay this way. This is where we are right now, and this is a reflection of policies from the past. But it doesn't have to be. We are the system, and if we can stay motivated to change it, it can change.
I love it. That actually segues nicely into the next couple of questions, and they're sort of about the system at large. The one thing you mentioned was ascribing that burnout or occupational burnout is frequently a systems a problem. It's related to the system or systems issue, which removes it from the person, but also in some ways can decrease the agency of the person because they're not the system, and changing the system can seem impossible. And so, how do you balance that? Not wanting to blame a person, obviously, for occupational burnout, but also not ascribing it to something that then becomes completely outside of them and unchangeable.
I don't think any of us could have gone through the past 2 years and not seen what is problematic about medicine. I think it was barely working in lots of ways prior to this, and this just exposed all the fault lines in our system. It is a huge lift, right? Like, not any one of us can change these big systemic issues alone. But think about what an incredible, gift, in a sense, this awareness is that we have now. I bet each of us could list 10 things that need to change in medicine and have some agreement on it that we couldn't have had 2 years ago. So I've always felt that if physicians and patients actually understood that they wanted the same things for each other, that the power in that, we could actually be unstoppable, but we haven't really leaned into our power.
And the next question gets at maybe what leaning in would look like. The question says, you discussed institutional changes, and it seems as though many institutions will use things like free food or wellness seminars when more tangible, at least to maybe some of the people, ways of helping with occupational burnout exist. Do you have recommendations for how physicians can engage with institutional stakeholders to get the things that they need to reduce their burnout?
Yeah, I mean, we almost shot the nice lady who came into the ICU with the snack cart because, patients were dying and everyone loves cookies, but like there was no proportionality to like our experience in the intervention, and that mismatch made us feel really unseen. And so I think that's a really good point, that we have to be able to articulate what needs to change. What we're finding, in that bucket of agency is flexible hours, being able to, some people want to start clinic early and end early. Some people want to start late and end late. Some people want to work an unconventional schedule. Having more choice in how we spend our time, certainly having space to fulfill our personal development goals. Those are things that we can advocate for. We obviously have to work with leadership to make those things happen, but it's not impossible.
And do you have ways, as obviously you are an advocate, do you have ways that you approach those situations that can be practically useful to the people in the audience, say that they could say, well, I could take this thing I want and bring that to my leadership in this way?
So what I've learned, and this may sound very basic, is that everyone wants solutions. I've rarely seen a leader who is deflated in the face of a potential solution. What more often happens is that people just come with the problem and can't articulate what change would look like. And so one of the things that I think was effective at Henry Ford was our chief wellness officer did focus groups, aggregated all of the information from all of the groups that were most affected. And we're like, here, these are the 5 changes that would actually feel like we have made a tangible difference. And it was things like, we're not looking at RVUs right now because that's dumb, because we're constantly getting pulled to go do swabs. And there were sort of smaller things about how we account for time away. So no one has to use their PTO if they need time off. Certainly if you're sick, none of that counts this year. All vacation could be carried over because no one could take vacation. So there were changes at the Board of Governor level that really people felt heard. And, enough small changes and you start to feel like maybe it is adding up to a decent change.
Hmm. Yeah. It sounds like you have, I mean, obviously from health systems, they all run differently, but you had somebody, a chief wellness officer, reaching out to you, admitting that, recognizing a problem and reaching out. That helps a lot, I'd imagine.
Yeah.
Yeah.
That was after we almost shot her with the stick.
Right. After the
So
cookie woman
it
went
was a
screaming.
graded
Yes.
intervention.
Can you liken what's going on now? Maybe this is your own personal experience or something else. I think a lot of people thinking this is like and then they say a war or a previous disease. Is this like something else for you that people can help get their heads around?
It's interesting. In our peer processing sessions, I'll never forget there was a Vietnam vet who he's sort of old and grizzled and he's been doing respiratory therapy for like 87 years, like can build a vent in his garage. And, we were complaining about how difficult it was to go home to people who were frustrated about Zoom and, navigating things that seemed really small. And he told us, you can't expect them to understand because it's just like war. We have gone through something that no one else will understand. And you have to let go of that idea. And in that moment, I did believe him. It felt true to me. And what I've come to believe instead is that while everyone's experience of this is different, and we might not have the same material experience of it, we have the same emotions. So one of the reasons the peer processing group was so effective was because we could look at each other and say, okay, I didn't experience that, but I too have felt shame. I didn't experience that, but I too have felt that moral injury of not being able to do what my patient needed. And we started to feel seen and understood and like a community. And I really think that's something that's missing just nationally right now. We've all atomized our experiences to such an extent that we think no one can possibly understand what we know. And if we can be vulnerable and share them, which I'll admit I couldn't do over Thanksgiving because I was burnt out on it, but if we can, there's a chance that people will recognize themselves in the experience of the emotion, if not the experience themselves. And so that's something a space I'm kind of trying to work in right now.
Yeah, I like that. I appreciate that. Thank you. And I think we have time just for one last question, if you would, and I'll steal this last question. I think a lot about the trainees, obviously, at all levels, and I think that they are a particularly vulnerable group. Has your experience or your group, have they done anything particular for trainees and seeing them in a special space? And I think they're also, the trainees are open to this sort of almost tertiary trauma, which is seeing the people that they love and respect go through a trauma and not necessarily behave as they would in a sunnier time.
Yeah.
Anything on those thoughts, anything to do with our trainees, medical students, residents?
I've sort of always believed that there's never going to be one intervention that suits everyone. And so what we've tried to do is just make different entry points to the experience of processing for our trainees, because some people will really benefit from a peer processing group where they talk about their experiences. Some people just really want an Xbox in the call room so that they can unplug for 15 minutes and not think about anything else. And some people want narrative medicine sessions, and so we make those available. Some people really want to have more agency in terms of choosing electives where they might have less COVID care. Mm-hmm. And so again, working within those boxes of decreasing the frustrations and increasing agency and allowing a little more choice, as well as providing a space for reflection and processing. I think we owe them that.
Love it. Couldn't agree more. Thank you very much. Thank you for being here today, Dr. Awdish. Thank you very much for sharing your incredibly personal story with the world, but also with us. It's changed a lot of lives, and I just want to say thank you personally.
In person next time.
Next time for sure. You got it. Take care.
Bye.